Whew.
And I'll start recording. Then maybe we'll give people a minute.
You know, I have to admit that this meeting is like 1,000% preferable than the school board meeting that's going on right now. It's happening right now around the closures and all that. That's going to be a marathon.
I heard the last one went till 3 a.m., didn't it?
Something like that. And this one probably, it'll, yeah, because all those school communities that think they're getting closed, they're going to show up. And all the people whose kids are affected, they're going to show up. And it's going to be a lot. So I'm glad to be here with you.
Glad to be here. All right, we're recording team. I'm going to let, so far I've only let in interpreters and CAG members, but I'll let in a couple other people, and then maybe we give it a moment, just because I think we're still missing even some county folks as well.
Okay.
I will admit everybody though. Here they come.
And we need the interpreters.
Yes.
Thank you.
Yep. For sure. I'll make my announcement in a second.
Okay.
Thanks. Okay. Well, we can get started. Welcome to the 20th Alameda County COVID-19 Community Advisory Group for the 20th time we've met. And I just wanted to announce that we have live interpretation in Spanish, and you can use the globe below to, let's see, hold on. Sorry, to select your language. And we also have live interpretation in sign language and closed captioning. If perhaps you could just repeat the instructions in Spanish, then I will turn on interpretation, please. Maybe Maria or Jasmine, thank you.
Sí. Hola, buenas tardes, gracias por estar en esta reunión. Hay interpretación en español disponible. También tenemos hoy interpretación en lenguaje de señas, pero para buscar la interpretación en español va a haber un globo abajo en unos momentos y ahí usted puede elegir su idioma de español. Gracias.
Thank you. I will start it now.
Thank you.
Okay, great. And yes, as a reminder, we have interpretation and closed captioning, or interpretation in American Sign Language and closed captioning. The instructions are on the screen, and we are live streaming to YouTube as well. If you have questions, we ask you to put them in the chat, and we will do our best to answer. And finally, please mute yourself if you're not speaking. The last friendly reminder is for speakers to speak slowly so that our interpreters may keep up. And I will pass it over to Greg, our chair, one of our co-chairs.
Thank you so much, Lauren. My name is Greg Hodge. Welcome to this meeting of the COVAX. This advisory group has been meeting for the better part, almost 2 years now. And I want to thank everybody for your contribution. As we always do, we want to start with an acknowledgement of our Native American brothers and sisters and the land that we sit on here in Ohlone country, unless you're in a different part of the country. and that the folks thousands of years ago who were here were stewards of this land, were farmer people, fisher people, gatherers, and had families just like we do. And so we acknowledge their descendants who are our neighbors and friends and colleagues. We also acknowledge our ancestors. No matter what community you come from, you're standing on somebody's shoulders. It's African American History Month, and so there's a certain recognition of the history of Black folks. And, you know, Black History Month is not Black history, it's American history and the contributions of African Americans who are part of this country, as well as global history. And so all of our stories are important. We won't get into a conversation about CRT because I just feel like just teach the children the truth and we'll be a lot better for it. And so with that, we acknowledge, you know, folks in the medical sciences like Charles Drew and others who try to keep their communities healthy in their time. And it's exactly what this group is trying to do. We also want to acknowledge that there's a lot going on in our communities, that there is an increase in street violence. COVID is still an issue for most of our families, especially our most vulnerable communities. And that as we do this work, we keep in mind those families who are dealing with some immediacy of food insecurity and not having to work and being able to pay their rents, and a lot of fear and anxiety. As well as, you know, things like what happened over at the Kume Spa the other day, where someone lost their life, and, you know, violence affects all of us. And so for all those folks who have passed away during COVID, all those folks who have been affected by street violence and domestic violence and state violence, I want to just take a moment of silence and take a deep breath, because breathing is not optional. It's something that we have to do. And just I want to take a moment for everybody. Just take a moment, take a deep breath tonight. And exhale. And take one more breath for your grandmamas and grandfathers, abuelas and tias, people who we honor in our families. Take a breath for them. And lastly, we're going to take a breath for those children who are yet to be born, that they might be born into a better world because of our work. And so one more breath for them. I want to thank you for that, and thank you on behalf of Nestor Castillo and Kimmy Watkins-Tart. We're the terrific trio of co-facilitators for these conversations, and I'm glad you all are here with us tonight. We're going to hear some county updates, as we always do, and then we're going to follow the format that we used last time, which is to have some Zoom breakouts to be able to ask you all to give us some feedback and talk with each other, and we'll give you those prompts as we get to it. And then we'll have a little bit of time before we close out tonight for some partner updates. So with that, I'm going to turn it over to the fearless, the great, the smart, the wonderful Kimmy Watkins-Tart. You got it, Kimmy.
Oh, I love all of that, Greg. Thank you. Thank you. We're going to start by giving, update as we always do. And I think that, and Lauren, you're going to not like this when we say this, but I think we're going to flip. We're going to wait for Dr. Moss. He is coming out of another meeting. And so we're going to start with Donata.
Okay. I can get those slides ready. Let's see. Donata, we start at vaccine data. Oh no.
Yeah,
Nope,
after that. I think I only have 3 slides, so.
Okay, I think I got you. Okay. Should we get started, or was that
Sure.
the intro? Okay.
Yeah, go ahead.
Very much.
What I will say before Donata gets started, I apologize, Lauren, is that we're going to give opportunity for you all to ask questions, and then in the breakout, we'll have more time for discussion. And so what we try to do is put things in front of you that are really current right now to kind of tee up the conversation that we really hope to have in the breakout sessions. So Donata, thank you.
Right, thank you, and good evening, everyone. So Dr. Moss was really going to set the stage for some of the things that I was going to share with you this evening, but he can, definitely fill in and give you that transition. What I wanted to talk a little bit about this evening is really what our COVID Prevention and Mitigation Services Division is focused on right now, what our current priorities are. and talk to you a little bit about some of our transition plans and what COVID division might look like in the near future. So last time I presented a little bit more in detail about what our current priorities are. So I'm just going to really summarize that a little bit. So for our case investigations, we're continuing to focus on our unvaccinated 65 and over. Although our cases have come down considerably, we don't have thousands of cases a day that are coming into CalConnect. We're still prioritizing with that group, as well as our early learning facilities, which primarily we're focused on the 5 and under group. We also have an additional queue, a priority queue based on zip codes to make sure that people in priority neighborhoods have access to resources, for example, food, housing, the ARCH stipend that has recently been rolled out. So that continues to be a priority for us as well. For our outbreak settings, our high-risk congregate settings, such as our long-term care facilities, specifically our SNFs, there's a little bit of background noise.
Yeah, thank you for that, Donata. Somebody's got another conversation in the background. If you could just mute yourself, that'd be great.
I'm muting some people too.
Right.
So please don't take offense. We look forward to hearing from you when it's your turn.
So for outbreak investigations, we continue to focus on our long-term care facilities, for example, our SNFs and our residential care facilities for the elderly, our correctional facilities, and our shelters, where we tend to see a higher severe outcomes when there's outbreaks in those settings. And for our vaccinations unit, we continue to focus on the remaining unvaccinated in our county. So there's still, I think we're at about just about 82% fully vaccinated in our county. So we still have a little bit of work to do, and we want to continue to provide boosters. We also have a large list of homebound. We've been working with Alameda Lines to get a nice list of homebound that we're reaching out to provide that service. And then more recently, we're planning on focusing on or providing resources to our pediatrics, the 6 month to 4 year olds. So right now we're really looking at assessing the need there and working with our healthcare system to identify what our healthcare partners can do versus what gap we will be filling. And in terms of our testing, we want to continue to provide access, of course, to testing for our communities, especially our lower resource communities, but really also provide guidance in terms of home testing resources that are available and continuing to come out. So in terms of transitions, I just want to talk a little bit about that. We've been talking already about moving away from universal case investigations in the future. Right now, I just want to just acknowledge, and I'm so grateful for the amazing CBO partners that we've had to work with during our COVID response. I mean, they've helped us tremendously with all of our case investigations, our contact tracing, our community resources support as well, all the way back to, the middle of 2020. So during our previous surges, we've prioritized our case investigations and reduced our contact tracing. But with Omicron, really the numbers were so high that it was really beyond our daily capacity to reach every single individual who was a positive case. So we did prioritize based on our highest risk for severe health outcomes. We have now seen older adults that really have borne the brunt of death and hospitalizations in our county. So that's why we really needed to focus on those populations. But as we start looking at transitioning to our COVID response work post-Omicron, we will continue to look at public health case investigation really as a population level intervention. And our primary responsibility is to continue to identify cases and to break disease transmission. So part of our COVID transition work will look at really aligning the priority functions in our COVID division. So continuing our case investigations, but really focused, and then coordinating that closely with our outbreak team, which is really where we started at the beginning of 2020, is that whole team was one team, and then we split it out to have our CBO teams coordinate the CICT work. But eventually we're going to combine those efforts and align the priorities there. We also want to make sure we have increased capacity for high-risk settings, which I mentioned a little bit earlier. really looking at those high-risk settings for severe outcomes of severe health outcomes. And we also want to continue to be able to provide surveillance and testing. We really want to be able to identify and have an early warning system in place when there is someone that's sick, that's someone that's out of the ordinary based on various factors like vaccinations status or comorbidities. So we'll continue to look at the data as well as some of those risk factors. So in essence, we're really looking to move more to tailored support for families overarchingly and more broadly. But this is really a continuation of what we've already been doing, but we will be working to separate really out the resource part from the COVID investigations work. And then once we get out of this surge, we really want to focus on restarting our prevention model, which we started in our long-term care outbreak team, which we would like to start applying to other settings. So we'll be looking at that in the near future. And then looking a little further down into the future, we continue to provide support for high-risk settings, but we really want to be more there as a provide technical assistance to these other non-high-risk settings. We also want to continue prevention and mitigation approaches. So really working with our communities and our coalition teams, for example, to focus on messaging and prevention and mitigation messaging so that we have a consistent message across our county, really, for people to hear. And of course, we want to continue to provide tools and resources for individuals to make informed decisions. So whether it's, it really, there's going to be more therapeutics coming out. So we want to make sure people have access to resources, those types of resources, housing, food, financial resources for and masking. No matter what our policy is for masking, we want to continue to be providing guidance to our communities about masking as this COVID pandemic shifts. And then lastly, I just want to mention that at some point in the future, maybe this year and maybe towards the end of this year, we will transition this work back to our acute communicable disease unit in our public health department. And that's where it would have sat if it hadn't been a pandemic. So more to come on our transitions in future CAG meetings, but I just wanted to give you kind of an overview of where we are now and what it might look like in the near future and further towards the end of the year. And then I have just 2 more quick slides. I wanted to give you a quick update on testing. Our testing team and our communications team have come up with this great communication tool for our communities. We've seen some concerns about testing sites that are possibly not legal and possibly questionable. So we have come up with less is more. If you're going to a testing site, you want to check if it's legal, ethical, safe, and secure. Test kits really are, testing resources are free to anyone in the county. So any of our county sites, you shouldn't be asked for an insurance. You shouldn't be asked to provide your social security number. It should be affordable to you. Our staff and our contracted staff always wear protective equipment and gloves when they're moving from one individual to the next. So those are some things to look for. And our testing site and lab information are available to you. And so you should be you're able to kind of look and for these 4 key things when you have a questionable site. There's one more slide. There's another flyer that's coming out and maybe out already if you go to the next slide about the same topic, but just a little bit of a different graphic. Just again, some tips on what to look for at a testing site. Overall, our testing positivity continues to decline. So that's really great news. However, some of our at-risk neighborhoods, our lower resource communities still have pretty high testing rates, anywhere from 17 to 38%. And our highest test positivity is currently still in East Oakland, Hayward, and Fruitvale. But our surge is really coming down. Our test utilization was up to 10,000 tests per day, and now it's down to anywhere from 1,000 to 2,000. So yeah, just a quick update there on testing. So and that is all I have for this evening for COVID division.
Thank you, Donata. And now we'll shift over to Dr. Moss, who will talk with us about the data, where we are, and what's possibly to come.
Thanks, Kimmy, and apologies everyone, I'm late tonight, but let's go to the next slide. So first of all, just briefly, things have improved quite a bit from the peak of our winter wave, but it was a major wave, and we'll look at a picture in a second. But I think it's possible that as many as a third of our county residents got COVID during this winter. Now with home testing and infections that never get tested or reported, those don't necessarily go in the numbers, but there was quite a bit of COVID around, and we still have fairly high rates. Our case rate, we calculate it with a lag, 90 cases per 100,000 residents per day on January 31st, but it peaked at about 270 cases per 100,000 residents per day, about 3 times that. Last year, for reference, we peaked at, I think, 56 in the winter wave. Very high test positivity still, 12% of tests overall. It's a little bit higher in our most disadvantaged census tracts. That's also down from the peak. Hospitalizations, we have over 300 people in the hospital, over 50 in the intensive care unit. These are also down from their peaks. It's too early really to know the impact in terms of deaths from Omicron. Deaths tend to lag the peak and of even hospitalizations. And so I think we'll know more in the coming weeks, really what the cost was of this wave in terms of deaths. Next slide, please. So this is just our daily reported cases, and you can see that the peak, the spike, the highest number, January 4th, 6,000 cases were reported on that day alone, which is just, I think we peaked around 1,300 cases reported on a single day last winter. But things have declined steadily since then, almost in a straight line, a little bit slower than we thought, although the pace of decline seems to have picked up, and we are quite a bit lower, down under 1,000 cases reported every day in recent days, more maybe around 600-700. Next slide, please. And similarly, just same data, but looked at as a rate. And I have this up here, so you can see we're down about halfway from the peak here in this figure. Those colored lines at the bottom, those are those community transmission thresholds, those CDC community transmission thresholds that we used to use. And you can see there's so much virus around. The variant spread so easily this winter that it sort of made, I think it's forced a reckoning with those thresholds. That red line is high community transmission, but there's a huge range above that and that we've been sitting in. And this is slides from a week ago. We're already quite a bit lower than this, but we're not close to that red line, the threshold between substantial and high community transmission yet. So I think it just puts this whole wave in perspective. Next slide, please. For those of you interested in wastewater monitoring, the East Bay Mud wastewater influent is sampled for COVID. That it includes a little bit of Contra Costa, so El Cerrito, but then also Albany, Berkeley, Emeryville, Oakland, and Alameda, all in there. And what you can see is the winter wave and the decrease in COVID detected. You can hear from my assistant here in the background. He's looking for blueberries. You can see there's an improvement in this indicator. We're still learning how best to apply these, but I think this is also a reassuring sign there's less COVID around. And in fact, this is from a week ago. Next slide. The point of this slide, this is from our dashboard, just a reminder, vaccines really have held up. They've lowered the risk of infection, even though Omicron is able to cause infections in vaccinated people. We have seen lower rates of infection in fully vaccinated people compared with unvaccinated people. And when you're able to look by booster status, which we don't show here, boosters really add to that. So much lower risk of infection if you're boosted compared to unvaccinated people. And then if you look at hospitalizations, similarly, just a much lower rate of hospitalizations among vaccinated people, and then again among vaccinated and boosted people. Next slide, please. Vaccination progress continues. We're slowly ticking up at 82% of population fully vaccinated. The last group to become eligible, 5 to 11-year-olds, up to about 60% fully with at least one dose. Next slide, please. So I think one thing Kimmy asked me to raise in this meeting is, the issue and the question of, is this endemic? And I know you are hearing some experts use that term, and maybe other people are not using it. When I hear that term, it means something specific. It means we've reached a kind of balance between the virus's ability to infect people and our ability to resist infection. And I don't think we've hit balance yet. Certainly not if you look at this case curve. This is the whole pandemic, and on the far right is the Omicron winter wave, right? So clearly, the virus and our response to it, that is not in balance yet. Maybe it will be after this wave, but I'm just sorry, seeing Dr. Rhodes' comment in the chat. But we don't know for sure. It's the kind of thing that you really don't know in retrospect. It doesn't mean that it's not reasonable to start thinking about what's next. Where should we make changes to policy? We can't. We have throughout the pandemic made changes, and I think we continue to adjust our approach according to the risk to our communities and the tools we have available. So that's all fair game. But this is COVID is going to be with us. It's going to continue probably to cause waves, maybe even waves of severe disease, although hopefully not as bad as we've seen in the past. But it's possible. The other thing is, even if it were endemic, that doesn't mean that it's benign. You can have very serious illnesses that are endemic, that cause hospitalizations, deaths. Flu is a good example. We are in balance with seasonal flu, but it still causes a lot of severe illness every year. There are plenty of endemic infections that are serious public health threats that we continue to try to contain. Next slide. Okay, so this is a hypothetical, like what might an endemic pattern look like when we get there? Well, maybe it'll be seasonal waves, smaller waves of infection that happen. I don't know if this happens in 2023 and 2024. Maybe we'll see summer waves that are a little bit smaller. That's been the case so far. But the point is that we would be in more of a state of balance, and that I think that even if we saw severe disease, it would happen in a more predictable way, as opposed to sort of seeing something different every few months. Next slide, please. A lot of activity here in the Moss household. Similarly with hospitalizations, this is the actual hospitalizations going back to the start of the pandemic. You can see the two smaller summer waves and the two large winter waves. So I don't think, I hope that this is not our long-term state with spikes of hospitalization twice a year, including substantial winter waves. I hope that it gets better. Next slide, please. But maybe we'll have small waves in the winter. People getting hospitalized for COVID, not as many, but still requiring treatment. And there are always going to be people for whom vaccines don't work. There are always going to be people who are unvaccinated. Every year we add more children to our populations, or people may be moving in who may not have been vaccinated. So that risk will be there. Maybe immunity will wane. Not everybody will get a booster shot. but we're just not there yet. Next slide, please. So, okay, so we kind of covered this already, but just, and I know Janata touched on a lot of this stuff, but COVID is with us indefinitely. We're certainly better protected than we were, but I think we have to, you know, operate as if it's going to be there and it's going to go up and down, at least for the foreseeable future. We need to continue to support people to get vaccinated. I think testing access, particularly for sick people where there's work requirements, we need to make sure that our most impacted communities can access those things. And I think now, whatever happens with mask policy in the coming weeks, you know, we need to support ongoing masking. Masking will continue to be recommended no matter what. And I think a high quality mask has real benefits, and we want to make sure that people who need it or want it can get that. Education outreach, of course. I think Donata touched on a lot of this stuff. You know, care navigation is going to be important as more and more treatments come online, but as we still contend with the historical barriers to access to healthcare for some communities. Case investigation outbreak, I think Donata touched on this. We're happy to comment more, but you know, definitely time for a rethinking. At the same time, we need to keep working to protect those spaces, those congregate settings where the greatest risk is, and we need to be on guard for that possible severe variant of the future. No matter what, it may happen over a different time course, you know, maybe it's just masking, there are other things, but emergency requirements can't be with us forever, because we can't be in a state of emergency forever. At a certain point, we have to adjust. It's new normal. They will continue to ease. We don't have that many left, actually, but they may be needed again. And I think people need to just have that in the back of their mind, and we need to preserve the opportunity to use those by dialing them back when they're not as needed, so that we can dial them up when they are. And I think all of us, our families, our institutions, we're all going to need to manage the new normal. It's never going to be 2019 again. And we're going to need to figure out how to operate in a COVID world. I think is that my last slide? Hope so. Yeah.
All right, thank you very much. And Greg, I think we're going to take a few questions here and then more in the breakout.
Yeah, we wanted to give people a chance to ask any clarifying questions, and then when we get to the breakout, we really want to get deeper into questions that people have, and then also to hear back from you in terms of what communities, the communities that you're working in, what they're saying. Are they treating this as we're done, we're over? Or are they still being somewhat careful and you know, cautious about the behaviors that we know will make a difference in all this? So before we get to those discussion questions, or any additional questions for Nick or Donata, and would definitely welcome any of the other providers, Noha and Dr. Bruce and Kim, anybody else who is a clinician, anything you all want to add to the mix of information today.
I appreciate the presentations. Thank you. And I have a lot of questions, and I'm going to try to just start with maybe my top one, which is about the wastewater surveillance. That's exciting. As a potential, piece of new, I think, infrastructure or that can be, you know, part of our new normal, as you said. I'm curious right now, are we sequencing from that? Are we able to identify new variants of concern from the wastewater surveillance?
Yeah, you can sequence those specimens. I am not sure how much of the East Bay mud, if that's being done routinely. I know it has been done. It has been demonstrated that it has been done. I think some people are doing it more routinely, and that will probably be an increasing part of surveillance going forward. I think we still don't know how perfect it is, and you don't always know which variant, which variant is the variant that's going to take over until it starts happening. But I know that Santa Clara was able to detect Omicron pretty early on in their wastewater specimens. That was helpful to know it was there. And I don't know how well they can sort of tell how much of a specimen is one variant versus another. That would be useful, but I don't know if if the techniques are at that point yet. If others know.
Follow-up. Yeah, no, I guess my follow-up question then would be how will we use it? Because my understanding is that you know, that SARS-CoV-2 starts to be shed in the feces sort of even earlier than any other way that we might have to detect. So what would be the ways, or what might be the things we would do based on what we're finding out from the wastewater?
Well, so I think some of you may have heard this before, you know, the question of how closely we should follow cases. That case numbers are, some people have said, well, they don't mean as much. I find it very useful to follow cases because they rise before hospitalizations rise. That has remained true throughout, even when we know we're not getting every infection and when home testing is out there. At a certain point, they may not necessarily predict hospitalizations. But if people are testing less, or if we're not getting reports because people are home testing, we may not necessarily know a wave is hitting from our case report data. For now, I think we'll continue to at least get lab report data that really will show us an increase that suggests a wave is happening. Wastewater is another way that we can get that information, that we can know before the hospitalizations hit, hey, something's happening. And it does seem to do that. It's a pretty, like, I think that actually people are still sort of working out the rules, and it's done a little bit differently in different places, but we've come a long way. And it does seem to tell us pretty early on, oh, things are happening. So that's useful if, for example, we decide, hey, there is a bad variant circulating somewhere else in the world. Our wastewater data shows us that cases are increasing here. Maybe it's time for masks again, you know, or maybe other interventions, or maybe just communicating to people. Now is the time to be more careful. So that's how I envision it being used. But I think you're right. There's going to be even more application with, you know, variant screening, and maybe looking. This is also very early stage, but sort of looking at specific settings and locations. That's more complicated and cost intensive. And you have to really think about where you do that, because you can't like sample every school in Alameda County. It's a huge number of schools, but maybe there are certain settings where we do want to use setting specific wastewater monitoring.
Very helpful, thank you.
Cool. Thanks for that. Other questions? And that's just exciting kind of news, and I will refrain from any jokes about it being part of our early warning system. I could think of a lot. So anybody else, any other questions? We got to find some humor in this somewhere, right? Any other questions? Yes, Kathleen.
Yeah, I just I put a question in the chat that Lauren may need to put the cartoon back up again, but there was a cartoon at the bottom of the slide.
The graphic that had endemic, pandemic, and that one.
Yeah.
Go back one more or two more.
And I just wondered, Nick, if, you know, I felt like it talked to my eyes in a very useful way. And I just wanted
to excuse me, Kathleen, you're talking about the one that had the globes on it? It had like 3 globes at it was during Donata's presentation. Is that the one you meant?
It is.
Okay. It's in
Thank you, Greg.
That's it right there, 17.
There it is. Yeah. Number 17. Yeah. So just, I've not seen this before. And I just wondered, you know, if you and Kim and Noha and some other folks who like this, to me, this says something to my eyes that helps me understand the difference between these things. But I just want to make sure that you feel that it's telling the truth.
I did see this slide earlier today when we were preparing. I did not pay attention to the figure, but I actually think this is, at first glance, it looks pretty good. I haven't had a lot of chance to process. I don't know, what do others think?
Kim and Noha, be especially interested in your opinions about whether this is true and useful.
Yeah, it's kind of working for me, I think. Good catch. I just got 3 globes, but yeah, now looking at it, I think it does get a point across quickly. I guess the how do we know we're there kind of thing, but it does give the feeling. I think it doesn't have maybe the metrics that's you know, and things like that some of us want, but I don't think we'll have, because on some level it's still a little subjective, right? I mean, correct me if I'm wrong, Dr. Moss. I mean, like, it's kind of there when we say it's there. And when you say like we're in emergency, not in emergency, all these things we are sort of like compared to what, you know, and unfortunately with all that we've been through, I think there's somewhat of a desensitization or normalizing of something that is really pretty extreme. And so how we kind of say when we're there yet, are we there yet? But I agree, Dr. Clanton. I think this is probably the best I've seen of it. I haven't really, it seems like people are really fumbling with trying to explain it. And this probably does the best job of anything I've seen so far.
Yeah, I thought so too. I don't know, Lauren, if you know who created this, but anyway. So
one other thing
dropped it
that
in, right?
it doesn't have is that sort of time element. So one way to conceptualize whether something is epidemic or not is if the number of cases in a given time are more than you would expect. That's not, it's a given time and place, and this doesn't really have that time factor in there. But honestly, I think if it's just to sort of quickly distill this idea of particularly, you know, I think it's pretty good. It's not perfect, but I think it's pretty good.
And the reason, and I just wanted to comment, and the reason why, you know, having these kind of images, we're talking about this is because so many of us and all of you have been hearing in the public space out there, aren't we in an endemic? Isn't it that time yet? Why don't we just say that? And it's important for all of us to be comfortable talking about this in some fashion, or having some imagery to explain why it's not over yet. And what does it mean for something to be endemic? Is that really where the goal kind of thing? And does it mean that things aren't bad? And so this is the beginning of that conversation, I fear. And we'll be at this for a while. And so any thoughts that you all have about this moving forward, there'll be an opportunity to discuss in the breakout sessions as well.
Yeah.
I love it that it does not have, you know, the North America at the center of the globe. So I love that part of it. And anyway, I just really appreciate it. And I don't know if Kimmy or Lauren, if either of you know where this came from, but I'm really appreciating it.
Donata, do you know?
Yeah, I created the slide so I can get the source of the information and send that out.
Thank you,
Uh-huh.
One quick comment about this one, because taken together with the slide that Nick, you were kind of speculating on, you know, here's what endemic might look like in 2023, 2024, and being able to then put numbers to that a little bit. The second thing it makes me think about too is that if we had examples of infectious diseases that are endemic that we're familiar with. So is like our annual influenza typically endemic? Like you hit it at a particular season, you get a high incidence and then it kind of goes away. Is the HIV AIDS, you know, was that an endemic, was it pandemic at one point and it went to endemic? Or was it pandemic and it went through all three stages? But in other words, things that the average person is more familiar with that you could use over time. Because I'm thinking ahead, like what does this look like to stay prepared, to stay cautious, even in the new normal that we hope that we all get to?
Others may have an answer to this. I mean, I think that it's important to not get caught up in the nuances of that language and those definitions. You know, certainly we have a HIV pandemic ongoing, although one might argue it's more in a state of balance than it has been. And you know, but I think that the more important message is it's not really about, I mean, yes, at some point it will no longer be a declared pandemic. But really, I think the most important question for us is, you know, here in Alameda County, are there things that we can do to keep people, you know, reasonable things that we can do to keep people healthy? And what are they? And I think that there's going to continue to be a need for that for some time. And there still is with flu, even though we don't think of it as a, you know, an emergency. most years, although in 2009 we had a flu pandemic, and we'll have a flu pandemic again. We still vaccinate people for flu every year. We have a health officer requirement for healthcare workers tied to flu. Like they're, so I think really the issue is, are there things that we can and should be doing in our communities to protect people from COVID? And that is going to be with us for a long time, regardless of whether, the technical definition of, pandemic or epidemic is met.
Mm-hmm. Cool. Any other questions before we spend a little time in breakouts, going a little bit deeper in this? Anybody else?
I had a question about the contact tracing, and thank you, Donata, for kind of laying it out and trying to foreshadow where we might be going. And also thanks for the shout out, I think, to all of the folks that have been part of the contact tracing process up until now, and completely understand why we need a rethink and a reframe and a prioritization. But I guess my question is, where will that happen? How will that happen? Are those some collective conversations that we want to be having as far as prioritization? I know from the work that Roots is doing with the contact tracing team, there's certainly a sense of, some folks really, really need the resources. They're going to need to go to the hotel. They're going to need funds to safely isolate. They're going to need food to safely isolate. And those are really the ones that we want to sort of prioritize for the contact tracing. Then I know that in terms of wanting to make sure that people who are positive get connected to treatment if they're medically high risk, feels like the job of the testing site that's doing the testing, and not so much with contact tracing. But then I'm also speaking from doing both, so I'll flag that. But I guess the question really is, how and where will we be doing sort of this prioritization? Is that a conversation that will be happening here? Could it? And what will that look like? Because I think we still have, I really want to appreciate the public health department for doing sort of the zip code, the geographic prioritization, because I think that has been useful, at least, but it's definitely hard to quantify and to say to what extent did we stop spread, if that is the main goal. But maybe it's a secondary goal that we're getting people resources they need to safely isolate, but that feels like a higher priority, knowing that we can't get to everyone, especially in surge. So just kind of curious what you're thinking and kind of how you think this is going to be sort of discussed and prioritized.
Yeah, I mean, I can definitely start, and then Kimmy or Nick can jump in. But I think this forum here is definitely a good place to really start thinking about how we can keep our communities healthy after this Omicron surge. We do have our CBO partners right now focused on case investigations. We're really not doing a lot of contact tracing. We're really focused on the cases themselves and making sure that they have resources. But we do have our inquiries line as well, where people can get, if they need resources, they can call us and get resources. And even if we don't have this universal case investigation continuing, we would like to be able to at least be able to send resources to every case. So either through SMS or through some automatic email that goes out with information about isolation, information about masking, and resources. So that we will, planning on continuing moving forward. I think this is a good forum here to talk about how we can keep, all of us can together work to keep our communities healthy.
Yeah. Let me make a suggestion, Kimmy and Nestor. Given our time, why don't we pause this for a second, go into breakout groups, do for 20 minutes instead of that full 25, and we kind of gauge and see how much time we need, and then we can come back. Because I think that we can get a good conversation going about what else do folks want to know, the folks we haven't heard from, what are communities saying, and what are your talking points, and about, what are the message we need to send. And then third, in anticipation of lifting more restrictions, what do we need to be doing and saying at this moment in community? So you're gonna have facilitators in your group. We'll be taking notes. Let's take about 20 minutes in breakouts, and then we'll come back to the full group and hit the highlights of those questions if we can. And then that'll probably take, unless we have a community update, which we may not, then that'll take us to the 7 o'clock hour. Does that make sense? Is that okay for everybody? Okay, cool. All right, Lauren, you guys can put us in our breakouts.
Sure. So just wanted to make the announcement. Greg is going to be facilitating one group. Kimmy is going to be facilitating another, and Nestor will be here in the main room. Please select any room you'd like to be in. However, if you need Spanish language interpretation or sign language or closed captioning, please just stay in the main room here with Nestor's group. So I will open the breakout groups, and then please just select wherever you'd like to go. For some county people, I've already pre-assigned you. All right, I will open them now, and they will close in 20 minutes.
Great.
And if people don't choose self-select in a couple minutes, I will move you at random just to even it out. And forgive me, I think you can select breakout rooms at the bottom of the screen.
Okay, it looks like our room is getting about there. I'm trying to distinguish between county folks, interpreters, and our participants, our CAG participants. But it looks like we're about there. Before we jump into discussion, is there anyone who is using Spanish interpretation? So that way I can, because I can switch over to Spanish, it might make it easier to guide the discussion in Spanish. Okay. All right. Well, in that case, we'll just continue and we'll just see how it goes. So let's start with that first question of, after hearing some of this discussion, some of the questions that were raised, are there questions that we have left that are unanswered for folks at the county level that we can, or that we think would be useful to raise and to receive clarification? I know I have some of my own, but I always want to leave space for our participants. But are there any questions that we think haven't been raised that are critical or important to do so? Mary Lou, yes.
Well, hi, everybody, and thank you, Dr. Moss, for your presentation. It was really helpful to hear what you had to say. I have a couple of questions that aren't related specifically to what you spoke about, but that perhaps you could just talk a little bit about. I'm wondering if you can say a little bit about what the impact of the antiviral drugs that are being produced now and are sort of in the pipeline are going to be overall in terms of pandemic versus endemic, and what the county and those of us in this group can do to make best use of that resource, if there's anything we can do at all.
Yeah, great question. I think I put something in my slides about care navigation, but what I really mean is I think we need, as a health department and as a community of providers serving particularly those who have barriers to access to care, we want to make sure that those people can, in fact, if they're sick, get treatment for COVID using the available treatments if there's one that's right for them, or get pre-exposure prophylaxis. There's a medication now that you can give some people called Evusheld that reduces the risk of COVID, and that's been important for people with very weak immune systems, transplant patients, things like that. So there are things out there that are not necessarily well known, that people don't necessarily have easy access to, but they might benefit from. And I think we have a role in, at a minimum, educating and beyond that, hopefully helping people access those, because I think they have a benefit in terms of reducing severe disease. Now, some medications that we know of so far are better than others, and maybe more in the pipeline will be good, and maybe others will be less good. And some don't seem to work as well against Omicron, but they work against other variants, and that issue will stay with us. So I think it's still early days. I do think both those COVID-specific treatments and also just the overall approach to COVID medical care, which has got much better, does have, it reduces the impact of particularly around mortality. And I think also will continue to reduce the sort of severe disease hospitalizations, may reduce or impact how much long COVID we see and what long COVID looks like, but it's still early days. So it's hard to know what the full impact will be. But I'm also a public health person. I think while that stuff is important, and it's important to make sure that we're doing our best to promote access to those things, because as you know, the most well-resourced members of our communities are going to have no problem, and they had problems, but they certainly were able to get a hold of scarce drugs. If my text messages were any indication, that's going to happen. But there are people who aren't going to benefit from those unless we put in some work. But ultimately, at heart, I'm a public health person, which means I'm about prevention. Vaccine has to be the way to keep as many people protected from severe disease as possible, at least until proven otherwise. And so first and foremost, we need to continue to work to get people vaccinated, get people boosted. And for those who aren't doing that, we need to find a way to get them good masks, get them the highest quality masks, and make sure they know when to use it, when case rates are higher, when they're in places that are more dangerous. And there are other things I think that are going to be important as well. But an ounce of prevention is worth a pound of cure, right? And so I think that is going to continue to be the mainstay of our public health approach, regardless of whether it's classified as a pandemic or endemic condition.
Thank you.
Did that speak to it?
Yes, that's really helpful. Thank you.
Thank you for that question, Mary Lou. That it's an important one, I think, to raise, because I think there's similar questions being raised. Any other questions that have come up that we think are critical or important questions that we think should be addressed and also addressed in the larger group, right? That's part of it here, is how we're taking some of what we discuss here to the larger group.
Or just concerns or anxieties. We've been having these conversations internal to the department, and people have voiced a lot of concerns just about, the state masking news and about case investigations, all of this stuff. And I think this is the space where we really need to, hear from you all about those things.
Yeah. And if not, I can I'll take space and raise one myself, Dr. Moss. I think, can you because I think you did a great job of explaining of like the emergency measures, moving back and forth, like being flexible, right? And I think at least what I'm hearing just from friends, family members, is that they're like, oh, their news is saying that we're sort of out of this. And I think they sort of have this thought or belief that we're coming completely out of it, right? And it's like, well, the Super Bowl is in LA, so it can't be that bad, right? And the governor's not wearing his mask, and so and but those things have weight. Perception is an important, I think, way of how we communicate, or the way at least we interpret the communications. And so, if you could elaborate a little bit on that message, or at least the logic behind, right, why the governor might say, like, we're rescinding the mask mandate, right, why we're beginning to open up, why it's important to have some flexibility.
Yeah, I think there's a lot in here. So first of all, for a lot of people, it is over. It doesn't matter if I say there's an ongoing COVID risk and that you need to get vaccinated, you need to do these things. Some people never got vaccinated and they're like, I don't care. And some people are vaccinated and boosted and they're like, I'm ready to move on. I'm going to travel. I'm going to go to restaurants. I'm not going to worry. And so I really think that that's been true for a while, and it's only increasing with time. And yes, I think, statements by people like the governor and actions by the governor, that certainly plays a role as well. But that is happening no matter what. I don't know if I said this in this meeting, but of the 50 states, only 8 have mask mandates. California is one of, actually, I think it's 7. There are 7 states in the District of Columbia. They're almost all on the West Coast, right? People are approaching this differently. And that's not because the science is different. And frankly, it's not because the risk of COVID is different. If anything, the risk is probably about as low in the Bay Area as anywhere in the world in terms of, how vaccinated we are. But except maybe those few places left that are COVID zero, but it's really about values. I think that there's people are sort of conflating the scientific evidence with sort of the values, and a lot of places are saying, look, we're ready to move on. Maybe there's risk, maybe there's not. I think what's different about us locally is that we've always had a commitment to public health, community health, to trying to keep people as safe as possible, and to really buying into the things that will preserve that throughout the pandemic. And that, I think, continues even as many people in Alameda County and beyond are going to look forward to thinking about other things. But I think that we are going to have to keep providing. It's more. Let me answer like this. I think that our work is more focused in this kind of new normal, making sure that the people who want and need these types of support, that ounce of prevention I mentioned, the treatment that I mentioned, but also just an understanding of what's going on, that we support them. And I think that we need to operate from a public health department standpoint. We just need to operate in the sort of reality that if we need to preserve the ability to do those more substantial interventions when they're going to be most important and most beneficial. And that's when cases are rising, when hospitalizations are rising. That's when we really need to be prepared to step in. And I think if we're not careful now, we'll limit our ability to do that. And that will, again, have the greatest impact on the people, the most disadvantaged community members, So anyway, I think that hopefully that kind of partially answered your question, but that's how I'm thinking about these things.
Yeah, no, it does. Thank you. Definitely does. And we've been in this for 2 years now, and I don't know if it gets any easier, right? But I think there is learning that comes with the process, and the hope is that those lessons are being applied, right? My only fear, and not to take it too off the road here, is just at the global level, right? When we tend to think of ourselves regionally, but we're connected like never before. And when people travel, and inevitably as they will, the vaccine scarcity across the globe, right? That other places in the world that don't have. And so anyway, that's, I think, maybe beyond the scope of our meeting here, the global health inequities. But
but maybe over time, people here will go on to work on those issues because they're not going away, and we need to get people around the world. There will be ongoing global equity issues that need to be addressed, and those do affect us, absolutely, and they will continue to affect us.
Yeah. Any thoughts on what else we're hearing from the communities that we work with, what we're hearing on the ground, those sort of talking points and messages that we need to continue sort of, again, elaborating on, or continue crafting, or making more specific or more focused, as sort of Dr. Moss was saying? Anything else that we're hearing from our communities themselves? Mary Lou.
I'm sorry to be dominating the conversation here, but I'm wondering, Dr. Moss, if you can elaborate a little bit on the demographics of vaccination at this point. This may have been covered in the slides, but I didn't notice that it was. Are we seeing more vaccination in the younger set, or in the middle, or older, or is there any kind of lesson to be taken from that question in terms of planning for the public health response?
Yeah, I mean, I showed them very briefly. And I haven't looked. We do have sort of age and race sort of cross tabs. I haven't looked at those in the last few days, but the big picture is that younger people have lower rates. As you get older, you get higher and higher rates. And communities of color have lower rates, although we're missing a lot of data, and actually the gap between white, Latino, and Black residents is smaller than it was. But I think some of that is just because we're missing some data on race and ethnicity of vaccine recipients. But the bottom line is the younger you get, the lower the rates are, and then in particularly Black and Latino communities of color, there are relatively lower rates, although high rates compared to a lot of places. Mostly those have increased, but they've increased more slowly. The children, 5 to 11-year-olds, it went up very quickly early on. Then we got close to 60% with at least one dose, and it's kind of leveled out. We're higher. I think the state is closer to 40%, so we're a bit higher than the state. But and I think it's going to be. I think some families will take a long time to get their children vaccinated. It depends on the school vaccine requirement that may kick in the fall, but and I think with 0 to 4-year-olds, it'll be very slow as well. So there are communities, ages, groups in our county that have lower vaccine rates, and that is persisting. And I think we make very slow progress there, but we do still make progress.
Any other questions, folks?
And I just add one other thing to that is boosters have opened up a new universe that we're still I haven't even seen the crosstabs yet, but I expect that we're going to also see groups where booster uptake is slower. And that's a particular concern for me for people over age 50 who seem to have benefited the most from boosters during the winter surge. So I think we need to be on the lookout for that as well.
Can I just ask what you think might go on in terms of a fourth booster? I realize that there's so much inequity in that question. It's hard to even think about addressing it, but it is being recommended in some quarters. I'm wondering what you think about how that's going to
happen. Yeah. I mean, we're hearing the talk. I have not seen much convincing evidence that has a benefit. I think boosters, the recommendation was very strong, pretty clear, I think, for older adults that they really needed to get boosters in the fall. And for younger adults, it was less clear. And I think that there was a benefit. It probably reduced transmission a bit. And it probably did reduce some hospitalizations, particularly for people in that maybe 40 to 50 age range. But I don't think you get as much bang for your buck, at least this winter. Things could change over time. I don't think we got the greatest impact is really for boosters is really for the older adults. For fourth doses, I really don't know that we have evidence to suggest that there's going to be an impact in terms of severe disease for any group yet. I know there's a little bit of literature out there, but I think it's really too soon to call. And as you sort of indicated, I mean, there's, that vaccine may be a better use in other people's arms, the arms of people who haven't been vaccinated yet. There's certainly no shortage locally right now, but I think just the effort around getting people a fourth shot takes away from the importance of getting vaccine to people around the world who aren't yet vaccinated. So I think that is a real consideration, and we can't lose sight of it.
I will say, and this is more of an anecdote than any sort of hard data, but I had a friend who had been reaching out and asking a lot of questions about the vaccine with a lot of skepticism and doubt. and it was, and you know, they finally reached out and they, you know, this is not that long ago, you know, and I don't think I'm disclosing anything personal here because no names or anything, but you know, they said, okay, I finally got it. And I said, well, what changed your mind? What convinced you? And they said, well, my sister got it. Right. And so, you know, my sister got it and she finally convinced me, got the vaccine, and she convinced me to do it after she received the vaccine. So I think there's something still to be said around, you know, and this is what the public health department and other folks here in these meetings have been stressing all along, the importance of those messengers and those credible messengers. And that sometimes it's the people who are most intimate to us and close to us that will convince us, or seeing a family member get ill, or vice versa, right? Of course, we don't want it to get to that level, but you know, that's just one anecdote that I could share, and maybe helps us kind of get into that mindset of thinking about, with the last question, now that we're sort of lifting some of those restrictions, what do we need to be doing? What do we need to be saying, especially to those communities that we work with?
I think that question was directed to the group, but I am going to say that probably the people who are going to get vaccinated, because Dr. Nick Moss stood up there and said you should get vaccinated, those people have been vaccinated by now. And, you know, we do, you know, that kind of close person in your life, that counts for a lot. And maybe during Omicron, we'll see more people who have that firsthand experience.
Any other thoughts?
I was looking around who's in this group. We have some county staff and interpret. Oh wait, now we have some more people. So,
Or is it folks who are it's the rest of the
oh, it's we're coming back. Okay.
Are we all back? Is this me, Greg?
It's on you, Nestor. I think looks like we're all back.
I think we're actually still waiting for one more group.
20 of us. Yeah, there may be. Maybe it's a smaller group. Maybe there's 6 or 7 people. Let's give it a moment.
Okay.
Oh, yeah, for 60 seconds. Okay.
Yes.
I guess maybe they got extended a moment or two. Here we go.
That was one person, Greg. I don't know if that was the
Yeah, maybe not. Yeah, no, you're right. It was. I thought that everybody was coming back. It should be another 10 seconds or something. There we go. There we go. Cool. All right. You got it, Nestor.
Okay. I think that, yeah, that's everyone. Welcome back, everyone. It felt like the waiting time, you know, was stretched out for some of us because we were in a smaller group, and so there was less conversation happening. But that last group seems like there was maybe some really great conversation happening. So why don't we go to that last group who joined us, Kimmy, and do you want to give us a quick little report on what you all discussed and talked about?
So, you know, of course, we talked about lots of things. We didn't get to all of the questions, and we raised more questions. But Lauren, I believe, has the highlights of some of the things that came up and were shared in our group.
Sure. So I'll just sum up, we had a really great discussion, really talking about, Kimmy really framed it as we've had this population level response, and how can we now start to use the mechanisms that we've already built through COVID to link people to resources, food, housing, healthcare, et cetera. And so the question really got kicked back to the folks in our breakout group, which was a mix of different people who are programs or healthcare practitioners, et cetera, to ask like, where do you think needs are? Or some people are both healthcare practitioners and run programs. And so a lot of ideas flowed about the types of services that could continue to be provided through these mechanisms, where communication lines and resources should and could remain open between county and government structures and community-based organizations and other mechanisms and entities that serve community. So, you know, kudos for faith-based organizations that have been doing the work and can continue to be vehicles. People like PTA groups who are, you know, have human capital. There are resources that have been really valuable, like rent relief, paid sick leave, opportunities for people to be sheltered, at least temporarily, while they stabilized and try to stay safe. And then talking about how we can continue to work together to focus on coordinated campaigns around other health issues. An example would be colon cancer in March, where I think Umoja is already spearheading an initiative there. And that's where we just kind of got started.
Yeah. What I will just add is that when a question came up in terms of, you know, what we want to prioritize, what are we hearing from the community, what are we hearing from the work that we're doing, mental wellness, of course, came up large as something that we collectively have to figure out, and not just screening people, but actually providing mental wellness services for people, because that is going to be, we're already seeing it. So that definitely came up. What also came up as an important priority to maybe galvanize around is the paid sick leave that was made available for people who didn't have paid leave, so that they can stay home and when they're ill. As Dr. Moss mentioned, since we're going to be with this for a while, then won't we still need those structures so that people can safely stay home and recuperate? And so those are some highlights from what came up in our group. Is there anything else that we want to share with the group that we missed? Nope. All right. Nestor?
Thank you, Kimmy. That it was great to hear that. Greg, do you want to share what your group discussed?
Yeah, I can say a little bit, but I would love it if Nitu would jump in. That they were just note taker, but I will say this: that we had a great conversation. I want to thank everybody in the group, and I think part of what we talked about was just the particularities of specific groups. So, like shared in the disability community, there's some anxiety about easing restrictions and feeling like the rest of the world has kind of moved on, but that we need to communicate to friends and families and others who are in the disabilities community and around that community that they still are very much at risk of getting sick. Similarly, around childcare providers, that there's a whole a lot of challenges around things like the managing of test kits and predictability of when those test kits are coming, how, what kind of guidance needs to be followed in terms of using them, day laborers, and thank Gabriella for the point of view there is like, what will the organization that serve those day laborers communities be like? Is it going to be a hybrid model? What kind of hotline can we put together to help support the questions that get answered? And then a lot of stuff around mask fatigue, hesitancy, and the like. And let me just pause there, but let me give you a chance to any highlights that you want to draw our attention to on this.
Yeah, I mean, I think, we talk often of the individual level, but Gabriella, I think, brought up a good point that, as, organizations, how are we also talking with staff and planning, for organizations and businesses and workplaces and employers to adjust to never really going back to, again, 2019. What does the new normal look like? What does a hybrid model look like? And then, being able to provide guidance around that. In terms of other messages, shifting more from vaccine, specifically those first and second doses, and talking about boosters, questions around why you should get boosted. And then, what are people saying to folks when they ask about boosters or vaccine, focus on the facts, really highlighting the number of folks who have died from COVID, using that number as a way to demonstrate the impact of COVID. And then, in terms of masking, how do we talk about the need to mask, but also talk about the need to get vaccinated, and seeing that there's a link between those two things in folks' mind. And then normalizing masking in times when there isn't a surge. So having to readjust backwards and forwards, taking it off, taking it on, and instead really seeing it as something as you would do regularly. So those are, I think, some of the other things that jumped out to me.
Yeah, thank you for that. And the last thing I'd add to it is I raised a question around how are our K-12 students managing all this, because 3 weeks ago, they were on basically, protesting that the schools were not safe enough, that enough precautionary measures had not been taken. And that the sort of quote of the day from our group, I think, is that, young person says, that we've hopelessly tied politics to our health. And that the notion that, that following the science and being rational about it is difficult. And then putting it in the context of what could be school closures, decision that's being made in real time tonight by our Board of Education, and all of the rancor and all of the challenges around that, and thinking about like this is all happening in the context of COVID. And so those are among the things that we discuss. And I'll turn it back to you, Nestor.
Thank you, Greg and Nitu. Those were excellent. Sounded like you all had excellent discussion, and our group was a little bit smaller, and but that just meant we had more time with Dr. Moss, and we had him all to ourselves. But Mary Lou, your hand is up, so I'm going to use that as an opportunity to see if you would be willing to share some of the things that we talked about. And if you have a question, you could also raise it.
Sorry, my hand was up by accident. Well, we talked about whether or not the new antivirals coming down the pipeline might be useful, and what the role would be in terms of public health preparedness. Dr. Moss was reminding us that our role is not to be talking so much about treatment as about prevention, although the antivirals will play a role probably for some people. We have to watch out for the equity issues, obviously, because as we saw with the vaccinations and their availability in the early days. We talked a lot about the sort of demographics of what's going on in the county and in general, in terms of who's vaccinated and who's not, and what the steps might be to be mindful of those trends and continue to be sort of looking at what the solutions might be. And we talked a little bit about the sort of idea of sort of staying on task with remembering who has access and who doesn't have access to care, both generally and in the county, because that's really our main thrust here, is to figure out where the gaps are and to fill those gaps as best we can based on what we've learned over the last 2 years. That's probably all I can recall at the moment.
No, thank you, Mary Lou. I apologize for putting you on the spot, but
No problem.
that's great. And you know, I think some of the other things that we discussed a little bit that were some of the, I think, things that are connected to this idea that we might be easing restrictions, right? That perception is super important, and how, you know, and the sort of fatigue type, you know, that people will be getting together for the Super Bowl, right? And that people will be in a stadium watching a Super Bowl, and that's here in California, and the sort of, you know, the logic that's still, you know, that's being used to sort of think about how we are still navigating this, right? That is complicated, and that, you know, and that people still need to get vaccinated, and that, you know, that they're slowly coming around. Those who weren't interested in getting vaccinated are slowly still coming around. I had, just as an anecdote to share, a friend that was sending me messages, really skeptical about everything, but her sister got it, and that's when they decided that they would say, yeah, I'm going to get the vaccine, right? And so those personal is, as Dr. Moss said, it isn't because he's up here saying that everyone should be vaccinated. It's because the close, intimate people in our lives are going to be the ones that have the greatest, most profound effect on us. And, you know, it's those personal messengers that continue playing an important role. So that was a little bit of the discussion we had. I don't know if there was anything to add there. Ben, I know you were taking some notes, but I think we covered everything.
Yeah, I think you got all of it. The only one thing that I'm not sure was mentioned, where there was some discussion and questions about potential fourth doses or additional booster shots down the line.
That's right. Thanks, Ben. So we don't have a partner update, do we, Greg?
I don't think so, but maybe this is a good moment. Any announcements, any news flashes, anything anybody wants to add before we close out and we go like Oliver looking for blueberries?
I guess I will share. This is Jennifer Caban. I am stewarding our Alameda County Emergency Child Care Response Team. Next Thursday at 6:30 p.m., we're hosting a child care check-in focused on our providers, just to give them some further information related to child care guidance, the work of our resource and referral agencies, and First Five getting test kits out to providers and families and community. So that's happening. Feel free to touch base if you have any questions and getting registered.
Cool. Thank you for that. Anything else by way of announcement before we close out? All right. Well, hearing none, I think we can give you back 5 minutes of your life. We're getting done a little bit early. Kimmy, any last comment you want to make? Anything by way of just close out? But if not, I think we are ready to go have dinner or whatever else we're doing tonight.
I just want to thank everyone for coming and just, you know, appreciate your consistent partnership with us, and look forward to the future next month's meeting. So thank you.
Cool. And we want to thank our ASL interpreter. We want to thank our closed captioner. We want to thank our Spanish interpretation folks. They've been working really hard. Thank you all so much. And thanks, Jen, for sharing that file. We'll see you next time. Thank you all so much and have a great evening.
Thank you. Bye-bye.